Thank you, Shantanu. Come and join us. I think we have about 5 minutes of discussion time. If we have any remarks or any questions from the audience, we would be happy to take.
To Dr. Shantanu regarding imaging. I think there are a few techniques which are in pipeline for I'm not talking of the lesions etc. but for plaque characterization, which has I think in last in this year there are few techniques are there.
NIRS is a technique.
Yeah, so I thought if you can shed some.
NIRS is a technique. Yellow trial was a trial which was published. This was Mount Sinai group, where this basically you can lipid pool burden we can make out from the and TCFA. These are two things which can talk about the vulnerability of the plaque. Sometimes the lesions are not significant, less than 60-70%, but lipid pool burden is more, and they are TCFA. They are very vulnerable, and whether they should be treated. Now this is a very grey area. It's not a full answers are not known yet. Basically, NIRS is a technology which is launched in India. I didn't cover that because it becomes too exhaustive then.
This technology actually is incorporated with the CT scans. All the advanced CT scans in the US, they have these plaque characterization protocols. It's very surprising why the Indian CT scans are, they have not got this technology here. It's more than about 10-15 years old. Infrared spectroscopy and all those, it is incorporated in the CT scan. The CT scan will give you a very good picture, but somehow it does not come to India.
I think the techniques which are mentioned is fluoroscopic techniques and the OCT. On these techniques, we can do the plaque characterization.
Yes.
I think, Ajit, the most important is to have a technique which will identify the thin cap fibroatherioma. Because when you do an angiogram or even do an ordinary IVUS, you may not be able to pick it up. Because we see many patients who go to the gym, walking, jogging, certainly develop myocardial infarction. They come to the table and you find that what we call a minoca, that you find that the coronary arteries are normal. I think these are all thin cap fibroatherioma. I think which rupture, the fatty burden is too high, but the cap is very thin. I think until unless we have some technology, what Raju says, have something which can identify such, I think that is one thing which we should be waiting for.
I think the closest thing comes to mind is a CT, which could be able to see the lipid-rich plaques in this case. Also, at the same time, I would like to make a remark that we know that imaging makes a lot of difference, particularly in left vein angioplasties and if it is a complex angioplasty. Unfortunately, for reasons unknown, and maybe the cost factor comes in that both OCT as well as IVUS are used in only about 20% of the patients in India and only 40% of the patients in the Europe and only 40% in the United States of India. So it still remains as a 2A level of evidence B as far as IVUS imaging is concerned for all left main as well as for the complex angioplasty. I think it's going to change over the course of time once we come the optimal results.
So, in your opinion, why Illumin 4 failed? Why Illumin 4 failed to show the benefit?
Yeah, I think what Ziad Ali said, he always says is one is a COVID impact.
Yeah.
They have done a sub-analysis of before COVID and after COVID events. And there was the graphs were statistically getting separated pre-COVID. But during COVID, what he said, patients were not coming to the hospital. That is one reason. And second reason, what he said is even though OCTs were blinded for post-angiography, all patients underwent a OCT. Sometimes you know what has happened. And thirdly, the same operators are doing with OCT, without OCT. Always a mental shortcuts or a heuristic, what we call, develops. So your angiography always improves, basically. Angioplasty improves.
So, whether the trial did not take into account the real world scenario, like only using in complex patients where it is actually used?
No. Actually, this trial was a high-risk patients or high-risk subsets, basically.
Yeah.
High-risk lesions or high-risk patients. This was the inclusion criteria was high-risk patient or high-risk lesion. So it was a high-risk patient subset criteria only. It's not like that. And thirdly, I'll tell in ultimate trial, they had done IVUS guidance. And when they analyze in core lab, actually the optimization criteria which was achieved is just 45% of the patients could achieve optimization criteria in spite of in a trial scenario. So it's very difficult. And when they separated both groups together, those who had achieved the optimal IVUS guidance angioplasty, they had better results. Almost the event rates were just 2% as compared to in that arm only in imaging guidance. So similar thing must have happened in Illumin.
Thank you.
I think we have two more
Yeah,
questions,
okay.
one from Suresh.
Yeah. I think just a couple of points about left vein bifurcation, decay stenting, etc. I think one thing you have to realize, when the Chinese did the study, their criteria who would do or take part in a DK crush trial depended on the volume. The volume was at least 300 angioplasties a year, and of which at least 50 had to be DK crush techniques. And all of them were first scanned in the core lab before they were allowed to take part in the trial. So that's the level of competence of the cardiologists who are dealing with these studies. And that is being compared with everything else that's going on, which is not true at all. I think you're talking of apples and pears, really. So you need that level of skill to deliver that kind of result. If you do one DK crush in 3 months, you're not going to get the same kind of results at all. And you're going to have more problems about that.
Yeah.
Regarding CT scans, I think they are coming. Problem is our CT scans are bought by radiologists, not cardiologists. We are never consulted. So all the imaging related to us is that they're not interested in that. That's the problem.
It's a built-in thing. Even a little smart CT guy would, it comes color-coded. You remember the NOGA scans and all that stuff? We've been attending conferences. It's a pretty age-old technique.
So we are running short of time.
Okay.
Sir,
I think we'll
one practical question. Dr. Desai, PCI in LMCA looks very impressive when you talk. How many times you developed complications which required surgical intervention? Dr. Mehra is here. When you had to call surgeon to...
I don't think so. It's a frequent occasion. It is extremely rare. I think the competency as far as dealing the left main bifurcation lesion, as I said, the shaft and the ostium is not a problem at all. But if it is the bifurcation, and if it is really a complex bifurcation, I think with the IVUS guidance and with the availability of other modalities like rotablation, IVL and things are becoming much more easier.
No
fact,
surgical interventions required.
Yeah, absolutely.
Sir, I think that's, we have to.
Thank you.
Thank you all chairpersons and speakers for a very exciting session.